I'm going to present a second lecture of the urinary diversion, which is related to the previous lecture, which was the types of the urinary diversion. My name is Dr. Ahmed Abdurrashid, and my mediator is Dr. Naveed Ahmed Meher. The learning objective of today's presentation is the management of the urinary diversion, their complications, and the follow-up. How long should we follow the patient after urinary diversion, and what type of diversion we offer the patient, and everyone, it has its own advantage and disadvantage. Management of the urinary diversion, mostly we are going to talk about for the stomach care and psychological care of the stomach. The stomach care mostly which we offer is the site which we perform it is the iliac fossa or umbilicus, and the type it could be conduit and the cutaneous ureterostomy. And the stomal, most common problems of the stomal drainage it could be the dislodgement of the stoma and leakage and malodors. So we have to teach the patient how they manage it, how they care themselves, and also the family, some person who will change it properly. And the skin-related problem is excruciation and pain. We have to offer for them ointment, pain relief, and then they should know it properly. There are two types of the stoma bag. Two pieces stomal bag, which and one piece is stomal bag, and each one has a skin barrier adhesive tape which are attached to the skin, and stoma bag and the drainage bag.
How many types of stoma are there? Anybody knows? Stoma, how many types? There are the major two types, protruding stoma and there is flushing stoma. Protruding stoma may be in the form of vicusiplasty or simple flush stoma, or maybe from the umbilicus. While protruding stoma, there are either end ileostomy or either lobe ileostomy. They should protrude outside of the skin. The purpose of protruding out the side of the skin that to prevent the contact of urine or any contacts to the skin, like in ileostomy or in the ileal conduit. So the contents come directly to the back rather than contacting to the skin. However, flushing stoma usually performed in those continent pouches where the patient will empty by himself in the sort of catheter, Nilton catheter or sort of. So there is no sort of excretion in this also. So there are two major types, protruding and flush stoma.
Thank you, sir.
I would like to contradict with Dr. Faraj because when you are making cutaneous ureterostomy, they are usually flush, but there is no continence. So in those scenarios, there are chances that urine can come in contact with the skin. So what Rashid was trying to tell us by bringing a skin barrier or avoiding skin from direct contact with the urine because it can lead to the excoriation and the cascade of the problems afterward. But the rest of the things, Faraj told us rightly.
Yes, sir. Thank you.
Thank you, sir. And how to prevent for the skin problem? We should keep urine acidic, and we should regularly change the bag, and they should also select the right size of the skin barrier opening and empty regularly.
So how would you make the pH of the urine acidic? Anybody from audience, if anyone is there, because I can only see empty chairs from here.
We are also making urine acidic in management of stone disease. I think we give some oral medication, and so you people, I think, have done stone clinic also. So which medicine are giving for to make the urine little bit acidic to prevent stone formation? It can also use here, I think.
Port chlor. potassium chloride.
That will increase the pH, I guess. Potassium chloride.
Citrates and citrate syrup जो दे रहे होते हैं हम लोग.
Citrate will make it alkaline.
Ascorbic acid.
Sorry.
Vitamin C and ascorbic.
Yes, I must tell them and proceed forward.
Yes. And we have also the stomach other issue, which is social and psychological and sexual and sport and travel. So we have to tell the patient in detail and counsel them in detail. So we are talking about one by one. How will you, can the patient who has a stomach can be socialized? What will you offer them?
Really, how to make urine acidic? We didn't get the answer yet. I don't know, is ammonium chloride or sort of some we give, right?
Yes, sir.
Vitamin C or ascorbic acid. Your other
Sir Ahmed?
My other question is actually is how can we patient socially can a patient who has a stomach can be associated with the social to the environment? They can be socialized, and we should also offer them for the perfumes, familiar places that they can go, and caretaker who will tell them properly how to change the bag, everything. And they should have also psychologically, which actually psychologically patient group is supporting literature, caretaker, and partner, which is understandable how to change the stoma. And also those sort of patients who have stoma also those sort of patients who have stoma, they also will have same issue. They will teach them properly. And before you making also stoma, you have to tell the patient and show them videos, or any patient who has also stoma, so they can tell them, and they will have, they should be actually know that this is the normal issue, that they can live it and they can deal with their issue properly. And psychological assessment. And also there is another problem for the sport. They can play sport for the non-contact sports, tennis, squash, not football or rugby. And abdominal belt also you have to offer them. And travel also, you should make actually case summary for the patient. That case summary will tell actually any person who doesn't know, or the airport security, because they know they are not medically related people. When you write the case summary and they have it, they will know it when you check up actually. Otherwise, they will have a lot of issue. Extra supplies in hand is very important also. During the travel, they may have an issue or leakage, or they should change it easily, and know when to get help. Actually, they should know it properly. All this actually is you have to explain the patient in detail and their family also. That was all the stomach care. Now we are going to talk about the complications. Complication we can divide to bowel-related, ureter-related, stomach-related, or metabolic. So we are going to talk about one by one. Mostly complication is which is related to the bowel. Early, late complication is immediate post-op, prolonged. So leak or fistula, which occur immediately post-op. It can occur with the first 7 days or immediately post-op. And fistula also is longer procedure. obstruction, and elongation, and stricture, and volvulus, and ileus. All this related to the what type of the ileostomy you have done. And bowel-related factors that significantly contribute anastomosis breakdown, poor blood supply. Mostly when we do for the urinary diversion, last lecture we talked about in detail. When you dissect it, actually you have to take care of the mesentery and the blood supply of the part portion you are taking out. If you damage it, it will become ischemic. Later it will become more problem, anastomosis leak. Sepsis induced by fecal spillage. All this is actually we talked about last time. And both can cause ischemia. Drainage, which we place for the intra-abdominal anastomosis, it can increase also anastomosis failure. And anastomosis performed by radiated bowel likely will cause the failure. You should know history properly the patient before you offer diversion in detail. Ureter related, it could be.
Can you go back to one more slide, please? Yeah. What is elongation?
Anybody from the audience?
These are the bowel-related complications where Dr. Ahmed has mentioned elongation. What is the situation where elongation of bowel happens? Or maybe he's trying to tell us that course of hospital stay gets long. So what is this elongation? Anyone from the audience in the podium?
Naveed, sorry, I was late in this discussion. By this term, I don't know what the actual meaning is, but the intention, I think, was whenever something is being stretched because of the contents within it, then it has got the capacity to elongate. It has got the capacity to, for instance, you have started with an 18-centimeter long bowel segment, but in all practicality, after maybe 6 months or 1 year down the line, it will not remain 18 centimeter. Maybe it will be more, and that might be the cause of having a volvulus.
Exactly, sir. This is the rule that we usually apply when we are going to perform augmentation cystoplasty, because sometimes when there is capacity of 200 and 250, we usually try to take out 20 to 25 centimeter page, because gut has the property of elongation. Whenever you subject the bowel to some increased capacity, over the period of time, it stretches out and it can adjust to the capacity. So absolutely, sir, you're right. Yes, Amber.
Complication is related to the ureter related now is a urine leak or ureterointestinal stenosis, reflux, and pyelonephritis. So if we talk about the urine leak, why is a common urine leak mostly? Anybody from the audience?
Leak may be due to technical errors, or maybe to the necrosis of the distal part of the ureter due to excessive dissection. So either a surgical fault or either due to the necrosis of the distal part of the ureter where the anastomosis is done. So maybe there are other factors. Maybe Ahmed can tell us more.
You rightly said, sir, is morely is actually for the related for the technical error or anastomosis mostly becomes leak during immediately or later complications, which may sometimes need to re-anastomosis or bin technique. Mostly it's more common in the robotic iliac conduit, mostly patients. So we can see need more related complications.
Why? Why in robotic surgery this happens more often than an open or laparoscopic platform?
So we do it for intercarboreal.
So that means that your technique is faulty, or is it something else? Because this is a very big statement for something which is too costly an instrument. So if you are doing a robotic surgery and you think that the urinary leakage, the incidence is increased on robotic, then there is no use of a robot. It's a big statement. Naveed, you are the robotic surgeon amongst us, so you can tell us more.
There is no as such data or evidence that there is increased incidence of urinary leakage with robot. So that maybe there might be a lesser incidence because you can easily visualize things very clearly with laparoscopy and robotic surgery. So again, if there is increase in incidence with robotic surgery, that means the surgeon is at fault, not the robot. The principles are same. You have to ensure that there is adequate blood supply to the ureter as well as the gut portion of the gut that you are going to anastomose with the ureter, and it should be watertight, over the stent, and tension free. So these are all same principles that apply in whether open surgery, laparoscopic surgery, or robotic surgery, and you will get the better results. If you avoid or ignore any of the principles from all these things, then there are chances that you will end up in urinary leakage and failure of the anastomosis.
And just one more point, if you allow me to add, when you do a robotic surgery, and this is written in some of the articles, not on a wider randomized controlled trials, that if you do dissection of ureter, for instance, then because of the vision and the clarity with which you are seeing things, your dissection is very close to the adventitia of the ureter. If you are very close to the adventitia, then you might be having something on the vascular front, that is, you are compromising the smaller vessels which are supplying the ureter. So there has to be a safer distance at which you want to play with your scissors during dissection when you do a robotic surgery. And the same principle applies when you do open surgery also. You want to be away from adventitia. So this clearer vision, the 3D vision, and the depth perception on a robot, sometimes it sort of deceives you, and you become very near to the structure, and you are in terms of millimeters away from adventitial layer. In actuality, you have to be maybe in centimeters away from the adventitial layer. Naveed, what do you say about it?
Exactly, sir. Absolutely. And I would also like to add one thing from because whenever we used to make Monty from bowel segment, so there happened to be a few vessels that used to bleed, and Professor Murli always emphasized on not cauterizing those vessels but applying a stitch. So that electrocautery is something that can hinder the blood supply, and that can lead to the charring, and ultimately it will lead to the anastomotic failure or compromised blood supply to the edges.
Yes,
I agree, Dr. Naveed. And that is why it is also said that you don't try to bring ureter towards intestine. Take your intestine towards ureter, so that there should not be any tension on anastomosis. And Dr. Asad is rightly said that don't strip the adventitia away from the ureter. So that is important to avoid urinary leakage. And I will ask Dr. Ahmed why you gave this statement that there is more urinary leak by robotic surgery. Have you read somewhere, or it's your gut feeling? What?
No, it's written in the
You
Campbell.
read somewhere. So
When they compare it,
you should refer. If you are giving this statement, then you should quote that article or reference.
focus.
That would be a better way of
Yes.
putting something on the slide, because there are many people in this audience who will take your message as the final word, and they would rather say it during exam or anywhere else. So it has to be with a reference if something is coming which is like a surprise,
Yes,
right?
do not. And pyelonephritis also, which is another issue, we should address it for the patient who has a ureterostomy. The deterioration of the upper tract is usually a consequence of the lack of the ureter mobility, infection, stenosis, and less commonly caused by obstruction of the ureterointestinal anastomosis, which can cause for the upper urinary tract deterioration. If non-refluxing urinary conduit diversion is conducted, only 70% of the renal unit shows evidence of the pyelonephritis scarring after 3 months. And if refluxing anastomosis is constructed, 83% of the renal unit shows scarring. This is clearly showing that non-refluxing is better option. And this is the one half of the conduit. Both groups have significant bacteriuria, Ricci and Scanter, 1975. This is written from the Campbell.
Yes, you are right. Still, it is controversial whether to do refluxing or non-refluxing, because there are advantages of non-refluxing, like this pyelonephritis, and disadvantages of obstruction. So, in I think continent pouches, non-refluxing should be performed, because it causes the reflux and then pyelonephritis. So because for 3-4 hours that pouch is overfilled, and especially at night,
Yes, sir.
and people sometimes forget to empty, or they are busy with their work.
Yes.
So then reflux is there, and if infection is there because of CIC, most of the time there is infection in these patients, then there are more chances of pyelonephritis. So still it is debatable that which type of anastomosis, reimplantation,
Yes.
refluxing or non-refluxing.
Lisa, I would like to have your opinion regarding this notion that would you like to have your, whenever you want to use gut for conduit, to be clean of everything, there should be no bacteria at all, or are you too enthusiastic about having a cleansing mechanism mechanically as well as antibacterially? Because these were the days 1975, and it was the fashion that they want to clean the gut solely. So it has to be like asepsis. But now the enthusiasm is not so much.
Yeah, you are right.
आप किस तरफ हैं?
Initially, तो हम करते थे, we were doing this both mechanical and cleansing, but nowadays we are not preparing our patients, and they are not NPOs like after 12, not whole day, or maybe no enemas. And even we have given in our some patients carbohydrate drinks, but we could not apply it completely, like 12 up to 2 and then 4 to 6, which is mentioned in ERA's protocol. but people are doing, and there are lots of papers. There is a lot of material that the ERAS protocol should be applied on every case, and they have compared both the groups, and results are better in ERAS protocol. So for last, I think maybe 100 augmentations and these pouches, we are not doing the preparation. So now we are not seeing any problem in these cases. Yes.
So this is a very important point that Murali Sahab has pointed out, because now your last statement is incorrect as far as the whole world is concerned. The consensus now is there is a thing called microbiota. That means that it is a colony of bacteria, which is like a commensal. It is not a pathogen, and you should not be in a fix that you should remove it completely from the segment of bowel that you are using for different purpose. So your last statement would be a statement of last century, but not of this century, right?
Yes.
So this reference is not on.
And even Dr. Asaf, even we are now allowing on first day of the surgery, and we are removing NG first day in the morning, and we allow our patients to drink water, drink maybe sharbat. I do not take the name of sharbat. That will be the advertisement. So any type of, and as soon as they pass flatus, we start semi-solids and then solids. So in 2 to 3 days, patient used to start. But in our 2-3 cases, I remember they taken whole meal at first post-op day, because mistakenly, when I told him that boy that you now start semi-solids, he said, I ate my lunch today. So but they have gone uneventfully and nothing happened to them. And even in some cases, we haven't placed NG tube. Anesthetic is forgotten, or maybe patient pulled it out in recovery. So we then did not insert again. So they were also fine. And I think NG is not helpful. We should then avoid to pass NG as well. But out of some fear, I used to pass it. But we think we should not pass NG as well, because at first post-op day, I remember the statement of Professor Rensley. He was performing augmentation. He was saying that this ILL end-to-end anastomosis will heal in 6 hours. When we finish our surgery, that will be healed. Then I think no need of NG and ERAS protocol also suggests this. You mobilize your patient, even exercise. It's mentioned last night I was reading one paper. Exercise is recommended. And in pouches, a patient should be up and about for 8 hours out of 24 hours from first post-op day. Then your results are good. Recovery is fast and patient will go home soon rather than after 1 week, after 5 days or 4 days.
And there's another complication which is actually stoma related now, which is most commonly is prolapse, stenosis, bleeding, hernia. Bleeding can occur immediately post-op. And hernia is a peristomal hernia, which is later on we should manage for the either abdominal belt or all this is stoma related complications. And this is the most common issue which most probably we have seen. It is the metabolic complications, electrolyte abnormalities, alterum sensorium, abnormal drug metabolism, osteomalacia, and growth retardation. Electrolyte imbalance, that the factors that influence the amount of the solid and type of the absorption are segment of the bowel use, surface area of the bowel, the time of the urine is exposed to the bowel, concentration of the solute in the urine, renal function, and pH of the urine. We have to consider all these And then every segment we use from the bowel, it has its own complications, advantage and disadvantages, and the management also. You can see it properly, yes. This is a table which I taken from the Campbell, which is the syndrome of electrolyte disturbance in a patient whom bowel is interrupted in the urinary tract. Stomach, which I haven't seen in my life. Anybody from the audience? When do we perform stomach diversion repair?
कोई भी बताए भाई, स्टमक कभी देखा है यूज होता हुआ? नहीं, हमने भी नहीं किया है। नहीं, हमने भी नहीं, मैंने भी नहीं किया कभी मेरा। अच्छा, नहीं देखा। So there are problems with the stomach, lots of problems. That's why it is not being used. And whenever there is no small gut available, large gut available,
Yes, sir.
and
If you go to the library in the video section, so you can find one video of gastrocystoplasty, and you can, if you are interested in this, the whole thing of stomach use, what they do is they do partial gastrectomy, and along with the with its vessels coming from the transverse colon behind, there is a way to move it downwards and to augment the bladder. Now, this will cause one thing, and that is an advantage for the patient, since it is producing stomach is producing acid,
Yes.
and that acid is being protected naturally by glycosaminoglycans present within the stomach. The same thing is needed in the bladder. So, as compared to other segments of the intestine, the stomach is more suitable for the bladder environment as compared to any other part. So, this thing is there, but it is something which is I think not practiced anymore. Lately, I haven't come across not only here in adult population but also in pediatrics.
Yes.
But if somebody is interested, it's a 15-20 minutes video film. You can have it.
and there is good picture in Campbell as well. Taking the segment, and because vessels are very flexible and large, you can bring that segment towards bladder very easily.
Yes, sir.
But because of this hematuria, dysuria syndrome, and respiratory alkalosis, stomach is not being used very frequently or commonly nowadays.
The one mostly we have seen is jejunum, which is caused the hyperkalemic, hypochloromic metabolic acidosis. Which,
Professor Murli just said hematuria, dysuria syndrome. So, anybody knows what is this condition and what is the pathophysiology of hematuria, dysuria syndrome?
दूर दूर बैठे सारे, करीब कोई नहीं। नवी साहब आप ही बता दें।
That actually acid produced by gastric mucosa, it has some preventive role. Like we already mentioned that we need to make the pH of urine acidic, but the acid produced by stomach is very strong acid, hydrochloric acid. So the bladder mucosa itself, if you are going to perform cystoplasty, especially, the bladder mucosa is not resistant to that hydrochloric acid as compared to gastric mucosa. So what it can lead to the ulcer formation in bladder mucosa and ultimately end up in that dysuria and hematuria secondary to those ulcers in bladder mucosa. So this is the main reason why stomach is being avoided as a source for taking graft and performing cystoplasty. Otherwise, all other factors that are associated with stomach mucosa are very favorable for cystoplasty. But this one syndrome, one condition, it takes over all the advantages of gastric mucosa, and this is why it is being avoided worldwide in today's era.
Yes, right.
So, jejunum can cause hyperkalemic, hypochloremic metabolic acidosis, which later elevates for the renin angiotensin system, which causes absorption of the water and sodium and excretion of the potassium. So the symptoms patient will have it lethargy, nausea, vomiting, dehydration, muscle weakness, which we can manage for the IV hydration, sodium bicarbonate, thiazide diuretics. And if this management fails later on, then if the left reason, then we have to remove that segment of the, which is causing all these metabolic disorders. And the ileum and the colon, it causes a hypochromic metabolic acidosis, and which is a total potassium depletion and hypocalcemia, fatigue, nausea, lethargy, weakness. So this one we get sodium citrate, citric sodium bicarbonate, and chlorobrosamide and nitric acid. We can give for this medication is patient.
And why jejunum is not used frequently for augmentations, and it is only used for, can be used for conduit, not for continent pouches and augmentation. One is this metabolic problem, and second, mesentery is not so flexible. It's tight, so you and short. We cannot bring that segment towards
Yes,
bladder. So therefore, ileum and colon are mostly used for
mostly.
these pouches and cystoplasty. Dr. Naveed, am I right?
Absolutely.
For jejunum.
Yes, sir, you are right, because not only the mesentery is tight, but that blood supply, that cascades that we usually try to see on bringing that light in opposite direction. Those vessels, there are some gaps in between the vessels and ileum, while there are no gaps, and those junction where arteries and divide are very close to the surface of jejunum, and it becomes very difficult to harvest the segment from jejunum. But again, the most common thing that prevents surgeons from using jejunum for pouches and cystoplasty is that metabolic disease, especially the metabolism of sodium, that leads to very serious consequences. And anybody can please help me in explaining what is the main pathophysiology of that metabolism or circulation of sodium? What happens with the jejunal mucosa? Why sodium? In this chart, you can see that I cannot clearly appreciate because it is very blur over here in Sakhar, that sodium has only association with the jejunum, no any other part of the bowel. So what is that special in jejunum that leads to the flow or absorption or secretion of sodium in jejunum? So these are the very common things you are going to be asked if you are aspirant of any international or even national exam, and you happen to encounter Professor Hamad in exam that and you don't know anything about these things, then you are in deep trouble, because he is very keen to ask all these metabolic syndromes associated with all the parts of the gut. And you must know that jejunum is vicious circle that leads to the sodium imbalance. The selection of bowel segment depends upon 2-3 things. One, Professor Murli has advised the blood supply and the pattern of blood vessels. And other thing is the mucosal surface, whether it is absorptive, it is secretory, or it is inert. And the third thing is these metabolic problems associated with this mucosa.
Yes, sir. Altered sensorium mostly is a magnesium deficiency, nutritional debilation, or in relation magnesium wasting of the kidney. Drug intoxication is mostly those drugs which is excreted into the gastrointestinal. So if there's an issue, then they will have merbendazole, methotrexate, and some antibiotics. Immunogenic coma, which is common for those patients who have cirrhotic liver, and then they will have immunogenic coma. So patients who have, you have to take care of you have to see pre-operatively how was the liver function of the test patient, and then compared to that, you have to decide which one you are performing for the patient. Other related recurrent infection is urolithiasis, malabsorption syndrome, and malignancies. So common for the issues. Now we are coming for the last part of the presentation, which is a follow-up and protocol, depending on the primary disease and the type of the diversion which we perform. And then we have to focus for the stoma, diversion, on primary disease. All this we have to see it. Stoma follow-up, we have to see the immediate post-op, prolapse, skin issue, leak, hernia, all this we have to see. And diversion also, we have to know which part we use, bowel segment, and we have to see their metabolic issue also, continent, incontinent, electrolyte imbalance, capacity also, the pressure, upper tract, which we have talking about, bone disease, urolithiasis, and malignancy, all this. Benign primary disease, neurology, tuberculosis, idiopathic, and trauma. And malignancy, it could be recurrent or second malignancy. We have to see it actually. And this is the follow-up. Early evaluation, first 4 months, is to identify early ureteroiliac anastomotic structure, and intermediate period 4 months to 3 years, primarily focused for the detection of the cancer recurrence. The best image is the CT or other cross-sectional imaging, which also allows evaluation of the upper tract and reservoir stone on obstruction. The frequency of the follow-up can be risk adapted according to the pathology finding at the time of the cystectomy and the risk of the subsequent recurrence. Long follow-up beyond 3 years to detect bulge stones, upper tract obstructions, urothelial carcinoma arising from the urethra or upper tract. All this long. And this is another one for the new bladder, suggestive of the protocol, bladder cancer patient after cystectomy and orthodox diversion. Every 4th month of the first year, then every 6 months to 3 years, then annually. We have to offer the physical examination, including pelvic, rectal examination, serum, comprehensive metabolic panel, complete blood count, annual visit only, urethral wash, cytology, if carcinoma in situ, vitamin B12 level. We have to check also those patients who use for the. No, ma'am, those.
After that, is involved with the metabolism of folate and vitamin B12. And this segment, yes, just an idea. We have to see that.
Yes.
And which segment of the gut is involved with the metabolism of fat-soluble vitamins? Yes, correct. Jejuna. So it also depends not in every patient vitamin B12. It depends from segment to segment.
Yes.
Number one, we have to supplement these things as well in the follow-up of the patients. And as Dr. Naveed has explained us very well about the sodium level, so there are a few patients in which we usually give Sodament.
Yes.
And when? Why do we give Sodament?
Potassium debilitating.
तुक्का ही मार दो. हम लिखते हैं ना, सिर्फ सीआरएफ में तो नहीं लिखते ना.
बोलो, सही बोल रहे हो, जो पीछे से आवाज आई.
यस.
To correct the metabolic acidosis, I guess.
normal renal function में भी
नॉर्मल रीनल फंक्शन से भी फॉलो हमारे इलेक्ट्रिसिटी एब्नॉर्मलिटीज होती है खासतौर पे
conduits वगैरह उसमें भी हम लोग सप्लीमेंट करते हैं इन्हीं इश्यूज की वजह से when ileal segment is used and there is
where bicarb is low.
usually where
Especially
bicarb
in
is low.
normal renal
Usually where bicarb is low,
function.
but we usually give this on every follow-up if the follow-up bicarb levels are persistently low.
Yes. Sir, I want to ask also, the article they were saying actually which patient we should offer for the diversion, renal function, if the creatinine is greater than 2, EGFR is less. So in cancer patient, which type diversion we offer them? That one not.
Which diversion in
Renal failure patient, the protocol, sir.
ileal conduit is then preferred for those where there is serum creatinine more than 2 or EGFR is less than 40. Some people say less than 35 or 30. So in those cases, I think ileal conduit is the preferred diversion, not the continent pouch or orthotopic bladder, I think.
Okay, sir. So another,
Yes,
For-
doctor.
For continent pouch, I think the cutoff value for estimated GFR is around 60. But for orthotopic bladder, it should be more than 40 mils per minute, I guess. For orthotopic bladder, I'm sure it is more than 40, not less than 40. But for continent catheterizable stomas, it should be more than 60. And the mechanism we all know because there are chances, and that Ahmad Rashid has already mentioned, it is the nature of the procedure and that time duration that is urine is more associated or stored in the pouch. In continent catheterizable channel, because human are prone to make mistakes, there are chances that they don't empty their bladder timely, and it leads to the more transit time for the urine to stay in contact with that gut mucosa and more absorption of those contents of the urine. But in orthotopic bladder, as it is not usually associated with the self-intermittent catheterization, so there are chances that the patient goes for the voiding, and so it is clearly mentioned in Campbell about orthotopic bladder, it should be more than 40. Abbas bhai wants to add something.
Yes, regarding the Campbell sector, if you perform the orthotopic new bladders, it's absolutely right. The serum creatinine level is up to 2 milligrams per deciliter हो सकते हैं, and according to the EGFR rate हो सकते हैं, as you mentioned, it is CKD 3. You mentioned that हो सकते हैं over the 40 to 60. Ahmad Rashid, as stone formation is a long-standing complication of that sector, which type of stones formation occurs in these cases?
infective stones, sir.
What's the reason of infective stones?
Stasis, sir, of the urine, which is actually causes infective and ammonium splituria of the ammonium, which is precipitated formation of the ammonium magnesium phosphorus. Yes, and also I want to add also in the Campbell is written actually you have to offer the patient for the open surgery for the stone. They are not favoring for the endoscopic management of the stone. Why for that? Anybody?
No. मैं इसका आंसर दे दूं? आंसर दे दूं?
They will say, well, the fragment, when you do endoscopic fragment, you are not completely, the small fragment will remain there, and that fragment will make neither recurrent stone formation, mostly.
One of the reason is that when you place the cut, so when you perform cystolethalopexy, when you performs after fragmentations, you performs ELIC, so it supply pressure. So the gut the gut get damaged because of the high pressure of volume.
But I think the main cask of this statement is that you should remove all stones. If
Yes.
you can remove, I say that 1 centimeter stone in bladder, why to go for open surgery? Go for endoscopy, but aim should be that you remove all fragments.
Stones.
If you will leave fragment, then it will grow again. So I think both the options can be applied, less invasive and open. But aim should be that remove all these stones. Otherwise, there will be regrowth of the stones. Yeah.
And with the advancement in technology and availability of flexible scopes and laser fibers, it is easy to remove especially smaller stone endoscopically. But again, what you have just mentioned, that small fragments if left behind and not removed from the those pouches and augmented bladder or conduits. And we also know that the mucosa of that bowel segment is somewhat that has got the property of mucus production, and those small fragments get attached to that mucosa, and they provide needles for the stone formation. These patients are already prone for stone formation, and when there is a needles lying over there, there are chances of early recurrence, and chances of recurrence increase with the presence of needles in that lumen.
Yes.
Yes. This was the last slide. Thank you, everybody. Thank
Thank you.
Thank you, sir.
Thank you, Naveed sir.
Thank you, sir. Thank you.